I'll share the class. Can you see? Slides visible?
Yes, ma'am.
Okay, so today this is the third class of transfusion medicine or the blood banking, anything you can say. So we'll start with the third class. So today here I finished in the previous classes about the ABO blood grouping, isn't it? So how it is done, and then what are the antigens on the surface, what are the antibodies, and then even I told you about the Bombay blood group, isn't it? So now today we'll be starting with the RS system. So we'll talk about the RS system and clinical importance, and then we'll talk about the erythroblastosis fetalis or the hemolytic disease of the newborn. So now we'll come to the RS system, or this is also known as the, here mainly the D antigen or the capital D, not the small d. I told you about the capital H and then the small h, isn't it? So in case of that H antigen, so today also here we have to write the capital D because this D antigen is very significant, and then it is immunogenic, but the small d is not very immunogenic. So here we will talk about the RSD system. So this RS blood group system is the second in significance to the ABO blood group transfusion practice. So I told you first, whenever we will do the blood grouping in the blood bank, we do about the ABO blood grouping system, and then we will see whether the blood group is positive or negative, isn't it? So if this D antigen is present, then it becomes that blood group becomes positive, but if this D antigen is not present, then that becomes the negative blood group. So whenever in practical we'll ask you the questions like tell the blood group system, what do you know, then that time you have to tell particularly first this ABO blood group system and then the or D system or the RS system. So but don't say all these, if you know after that only you can say, but first you have to say this important one, ABO blood group system and then the RS system. So this is more important after the ABO blood group system. So now we'll go a little bit about the genetics of this RS system. So here this complete system is present on the chromosome 1. So this D antigen or the RS system is present on the chromosome 1. I told you last time that H antigen was there in the chromosome 16, isn't it? So this we will not ask, but still you have to know. So it is situated, or this is present on the chromosome 1. And here there are the co-dominant alleles are there. So here there will be the different alleles will be there. Some will be represented as capital D, and some others will be represented as the small d. And some will be represented as capital C, and some will be small c. And here likewise capital E is also there, and then the small e is also there. Understood here? So now there will be the co-dominant alleles will be there, so that will be represented as capital D, small d, capital C, small c, and then the capital E, and then the small e. So the antigens so formed are labeled as the D, capital D. So whenever the antigens are formed for these, so these are also labeled as the D antigen, capital D antigen, small d antigen, capital C antigen, small c antigen, E antigen, capital, and then the small e antigen. So, but here out of these small d, C, capital C, small c, capital E, small e, so only the capital D is highly immunogenic. So that's why whenever we will do the blood grouping, we will take it as the, whenever this D antigen is present, we call it as positive, and whenever this D antigen is absent, we call it as the negative. Understood here? Yes. Here basically,
yes, ma'am.
here basically you have to remember this genetic system or this RS system is situated on the chromosome 1, and there will be the different this co-dominant or the alleles will be there, and these are regarded as the CDE, isn't it? So it may be the capital C also, capital D also, capital E also, and same wise it will be the small also. But here, what? Please mute your mic. Somebody's sound is coming here. So now here these antigens formed, whatever antigen is formed, and that will be labeled as the D antigen, small d antigen, C antigen. So now out of all these CDE, there are 6, isn't it? So now here capital D antigen is highly immunogenic. That's why we call it as the D antigen in the RS system. So now we'll come, so I told you if the D antigen is present, then it is the RS positive, and if the D antigen is negative, then the person's blood group becomes the negative, isn't it? So here, by this time, you must be knowing many people are positive blood group, isn't it? So here 85% of the population, they will have this D antigen present on the surface of the RBC. So that's why they becomes the RS positive. And in about 15% of the population, this D antigen is absent on the cell surface or on the RBC surface. That's why it becomes the negative. Understood here? It's easy. So RS positive. So D antigen has to be present on the surface of the RBC. And so they become the RS positive people, and then it comprises 85% of the population. So in case of the RS negative people, this D antigen is absent on the surface of the RBC. So, and those are regarded as the RS negative, and then negative blood group is rare, I told you, isn't it? So I told you about even my friend's condition also. So here, whenever we take the percentage, 15% of the population will have this RS negative blood group. So now we'll come about the RS antibody. So in case of the ABO blood group system, were there antibodies in the plasma? Was there antibodies in the plasma? If it is the A blood group, then what was the antibody in the plasma?
Anti-B.
Anti-B, good. Okay. Now here, in case of these RH antibodies, it is not there in our body, isn't it? So unlike the ABO system, there are no naturally occurring antibodies against these RH antigens in the RS negative individual. So here, but I don't know, some of the students, like we will ask, suppose if there is D, and in practical, in during the Viva practical exam, we ask to the students, your previous seniors and all, suppose D antigen is there, and what is the antibody in the plasma? They will say anti-D. That is not okay. Here, in case of the, all may not say, but a few students will answer that way. So I'm telling you here, you have to tell, in case of the blood group A, in the plasma, there will be the anti-B. In case of the blood group O, there will be the anti-A and then the anti-B. But whenever we will ask what antibody is there, in case of the D antigen, you have to say there is no antigen. So I'm making you clear here. So I don't know, because of the exam tension or what, they will say the anti-D. So unlike ABO system, there are no naturally occurring antibodies against RS antigen in the RS negative individual. So to be the RS positive, the D antigen has to be there on the surface of the RBC, and that becomes the positive. And for the person who are the RS negative, the D antigen is not present. And you have to make clear that, or you have to understand, like in case of the ABO antibodies, there was the antibody ABO system, there were the antibodies in the plasma, but here for the D system or this RS system, there is no antibodies in the plasma or in the serum. So now we'll come to the immune antibodies. So here RH antibodies develop against the RH antigens after the exposure of the RH antigens following transfusion or pregnancy. So here this sentence means, suppose if a person is, mute your mic please. So here now, if a person is RS negative and he is transfused with the blood RS positive blood, that time that the body's immune mechanism, they will make the antibodies. Understood here? So those are the RS. Now we are talking about the immune antibodies. So here you see Rh antibodies develop against the Rh antigens after exposure to the Rh antigens following transfusion or pregnancy. So here during sometimes there can be mistake, isn't it? So in the blood bank also, and so that time if to a person, Rh negative person, if Rh positive blood is given, then at that time the Rh antibodies will be formed in the bodies, and then these Rh antibodies will attack this Rh positive, and then it will lead to the transfusion reaction. And similarly, in case of the pregnancy also, whenever the mother is Rh negative, that time if the baby is Rh positive and then the fetal blood goes into the mother's circulation, that time also these immune antibodies will develop, and it will lead to the later on in the subsequent pregnancies, it will lead to the destruction of the RBCs in the fetus, leading to the death of the fetus. Understood here? So now here Rh antibodies, so these known as the immune antibodies, and they develop against the Rh antigens after the exposure to the Rh antigen following transfusion or pregnancy. So now here the antibodies, these Rh antibodies are the immunoglobulin G type. Understood here? So there are different type of immunoglobulins, isn't it? G is there, M is there, E is there, isn't it? So A is there. So now here these antibodies are immunoglobulin G type, and these antibodies or these immunoglobulin G type, these are detected by the antiglobulin test, and that antiglobulin test is known as the MCOMS test. Understood here? So whenever the antibodies, Rh antibodies are formed in the body, and then it will lead to the hemolytic transfusion reaction, or during the pregnancy, whenever it will lead to the hemolysis, that time we can detect it by the antiglobulin test. The test name is antiglobulin test, and that is known as the MCOMS test. Another name for the antiglobulin test is known as the MCOMS test. So now here these Rh antibodies, whatever these are formed, they do not bind with the complement. Means so we have to add some this antiglobulin, and then only it will bind to the complement, and then it will show the aggregation. So that's why here it is written they do not bind to the, or they do not get attached to the complement. So now this slide is clear. Now basically here Rh antibodies are developed. Sometimes if with some mistake the positive blood transfusion is given to the transfusion is done to the negative person, and also in case of the this Rh negative mother, isn't it? So when the baby is Rh positive, and these antibodies are immunoglobulin G type, and then we can detect these antibodies by the MCOMS test, and they do not bind the complement system. So now we'll come to the clinical importance. So Rh incompatibility results in the hemolytic transfusion reactions and also the hemolytic disease of the newborn. So it will lead to the two things, this Rh incompatibility, a hemolytic transfusion reaction, and then the hemolytic disease of the newborn. So whenever hemolytic transfusion reaction, it will occur at the same time, isn't it? So whenever the transfusion is done, and another one, hemolytic disease of the newborn. So hemolytic disease of the newborn means, so in the newborn baby or in the fetus, it will lead to the hemolysis. So that's why it is known as the hemolytic disease of the newborn. Now we'll talk about the hemolytic disease of the newborn. So here, this hemolytic disease of the newborn occurs under the two situations. So it will occur under the two conditions. Understood here? One is the ABO incompatibility, and another one is the RS incompatibility. So now, the first line you see RS incompatibility of the fetus and then the mother. So here, when the fetus is RS positive and then the mother is RS negative, that time it becomes the RS incompatibility. Understood here? But in case of the ABO incompatibility, when the mother blood group is O and then the fetus blood group is AB, that time it becomes the ABO incompatibility. Understood here? So it's easy to remember also. So one is the RS incompatibility and another one is the ABO incompatibility. So I'll explain both of these situations or the conditions. So in case of the RS incompatibility, the fetus will be always RS positive and then the mother will be RS negative. If the fetus is RS negative, in case of the RS negative mother, there will be no problem. But if the fetus is RS positive, then there will be the incompatibility of the fetus will be there. RS incompatibility of the fetus can occur. So now in case of the ABO incompatibility, so here the mother has to be the O blood group and then the fetus, it can be either A blood group or the B blood group or the AB. Understood here? Clear? This slide is clear? You can, unmute your mic and say, did you understand or not?
Yes, ma'am.
Okay. Now for you people, mainly this RS incompatibility is important, and ABO incompatibility, if you know, then it's good, isn't it so? The way it is, RS incompatibility is very fatal, but the ABO incompatibility is not very fatal. So now we'll come to the main heading, that is the hemolytic disease. SDN means the hemolytic disease of the newborn due to RS incompatibility. So here it is also known as the erythroblastosis fetalis. So here erythroblastosis fetalis, here it is called because I'll tell you later that here the erythroblasts are there seen in the fetal blood. That's why it is also known as the erythroblastosis fetalis. Okay. So here hemolytic disease of the newborn due to RS incompatibility, and that is the erythroblastosis fetalis. So now we'll come to the erythroblastosis fetalis. So ABO incompatibility, I'll show you at the end one slide. Now we'll go to the erythroblastosis fetalis. So here an immune hemolytic anemia it is the immune hemolytic anemia affecting the fetus or the newborn baby. So here because of the immune antibodies development, so it will lead to the hemolysis of the blood of the RBCs of the baby or the infant. So it's the same thing. So an immune hemolytic anemia affecting the fetus / newborn baby. Understood here? So here this erythroblastosis fetalis occurs when the RS positive RBCs of the fetus cross the placenta in a RS negative mother. Now here the RS positive blood or the RBCs, it will go to the mother. The mother, has to be RS negative, and so it will lead to the formation of the anti-D antibodies. So these anti-RS antibodies or the anti-D antibodies, these are the immunoglobulin G type. So it's written in one word here. You can say anything. Anti-RS antibodies also you can say, or anti-D antibodies also you can say, or these immunoglobulins are the immunoglobulin G type. Understood here? So now we are talking about the erythroblastosis fetalis. So here it will lead to the anemia. So it is an immune hemolytic anemia. So whenever these antibodies are attached in the RBCs of the fetus, because mother will be sensitized, and then the this mother's antibodies will go to the fetus, and then it will attach to the RBCs of the baby, isn't it so? So this RBC attached so antibodies attach RBCs, it will go to the spleen of the fetus, and then it causes the destruction there. So it will lead to the anemia. This slide, did you understand? I'll just take the attendance once.
Ma'am,
Yes, please.
can you please explain
This one?
once more, like how destruction is, ma'am?
Okay. Now, here what happens, the baby is RS positive, isn't it so? Now in the next slide, I'm telling you, this is just a basic first you have to understand. So I'll tell you in detail, in first pregnancy what happens, and in the subsequent pregnancy what happens, and in the severe cases what happens to the baby. All these detail I'll tell you. So basically here, just to know you here, the RS positive RBC of the fetus, here the mother has to be RS negative, and then the baby should be RS positive. So when a baby's blood during the pregnancy and during the delivery, the RBCs can go to the mother's circulation, isn't it so, after the delivery. So that time, whenever this RS positive blood will go to the mother who is RS negative, that time what happens, this RS negative mother will not have, there will not be any D antigen, isn't it so? Now, whenever this RS positive or this D antigen of the fetus will go to the mother circulation, that time, because of the this immune system, there will be the formation of the antibodies against those D antigen. Understood here? So those D antigen against those D antigen, there will be formation of the antibodies. So those antigens are known as the anti-RH antibodies or the anti-D antibodies, and these are the immunoglobulin G type. And so whenever these D antibodies are formed in the mother's circulation, she will be sensitized, and then it will go to the fetus, and then it will cause the lysis of the RBC of the fetus. Did you understand a little bit?
Yes,
Excuse me, ma'am. I have a question.
Yes, please.
Only RS positive RBC crosses the placenta, or RH negative RBC from mother also can cross the placenta?
Actually, mother will have the different circulation. Mother's blood will not go to the baby. Did you understand? And then the fetus will have their different circulation. So there will be the placental, this barrier will be there. So only the nutrients will go, and sometimes these immunoglobulins or these antibodies which can cross the placental barrier, that can go to the fetus, but the RBC will not go. So suppose if mother is AB positive, suppose, and then the baby can be the A positive or the B positive, isn't it so? So then mother's blood will not go to the baby, and then the baby's blood will not go to the mother. So only at the time of the delivery, that RS positive fetuses, during the delivery, the placenta is attached to the uterus, isn't it so? So whenever the placenta is removed, that time the RBC can go to the mother circulation, and it can sensitize the mother's immune system for the formation of the antibodies. I'll tell you, it will come in detail. After finishing class, you can ask, okay? 10 to 11 will be there. Okay. Now you see here, during the first pregnancy, the fetus, isn't it so? So now here, for this erythroblastosis fetalis, mother has to be negative, and then the fetus has to be positive. It means that father should be positive, isn't it so? So now here the fetal RS positive RBCs, or this RS positive RBCs, they cross the placenta and enter the maternal circulation, and then the mother's immune system get exposed to the RH antigen or the D antigen. And then this D antigen is considered as a foreign antigen. So it will lead to the sensitization of the mother. Understood here? So here the fetus, it has to be positive, isn't it so? So that's why the RS positive RBCs, they cross the placenta, or the D antigen on the RBCs cross the placenta, and then it will enter the maternal circulation, and then the mother's immune system will be exposed to the RS antigen or the D antigen, isn't it so? So now here the mother's is RS negative, and she doesn't have this D antigen in her body. So whatever the D antigen or this RH antigen, it goes to the mother's circulation. That time the mother's circulation will think it as, or it will consider it as the foreign thing, isn't it so? That's why it will be, there will be the sensitization of the mother, and it will lead to the formation of the antibodies. Understood here? So as a result, anti-RS or the anti-D, that is the immunoglobulin G type, I told you, isn't it so? So these antibodies are formed in the mother's body. So initially, whenever there will be the initial sensitization will be there, that time there will be the immunoglobulin M type, and later on it becomes the immunoglobulin G type. Understood here? So immunoglobulin M type, it cannot, so there are depending upon their molecular weight, it has to cross the placental barrier. Understood here? So the immunoglobulin M type, it will not cross the placental barrier, but the immunoglobulin G type can cross the placental barrier, and it can lead to the lysis of the RBCs. This slide is clear?
Yes, ma'am.
Okay, first here the RS positive RBC or the D antigen, it has to go to the mother's immune system or in the mother's circulation, and then she will be exposed to that D antigen, and then the mother's body will consider it as the foreign, isn't it? So now here, whenever she doesn't have the D antigen in her whole body, then definitely the D antigen, whatever it has gone to the mother's circulation, it will be considered as foreign. So there will be the sensitization of the mother's this immune system. And so as a result, there is the formation of the anti-RH or anti-D antibodies that is formed in the mother's body. So at first, during the initial phase or in the starting, it will be of immunoglobulin M type, and later on it will be of the immunoglobulin G type. So now you see later this anti-D immunoglobulin G, that is the anti-RH. It can be said as anything, isn't it? So now by this time you have understood RH or the D antigen is the same thing, isn't it? So RS positive or the D antigen means the same thing. That is it will indicate the positive, isn't it? So blood. So later these anti-D immunoglobulins, antibodies, go from the mother to the baby, and it crosses the placenta and it will lyse the fetal red cells, resulting in the hemolytic disease of the newborn. So now whenever these anti-D immunoglobulins antibodies or the anti-D, it will go to the fetal circulation. So it has to cross the placenta. That's why it will lyse the RBCs in the fetus and it will lead to the hemolytic disease of the newborn. Understood here? So the initial sensitization of the mother means how it is sensitized. It occurs in the two ways, like the fetal RBC going to the mother. It may happen in the two ways. Understood here? So how it sensitized, it will be there. I'll tell you. So now during pregnancy, okay, one is during pregnancy and another one it is at the time of the delivery. During pregnancy, the sensitization, it occurs uncommon, it's not common. So very small amount of the RBC may cross the placenta. And so the immunoglobulin G formed usually not much in amount to cause harm to the first baby. Understood here? So if the first baby is RS positive, that time very small amount of the RBCs may cross the placenta, but that so the amount may be more in some, so this whatever immunoglobulin G amount may be more some in some the placental disease. So some there are also placental abnormalities are also more, isn't it? So here you have to understand during the first pregnancy there will be not if even if you tell no sensitization also, that is also okay, but very less will go. Very less amount of the RBCs may cross the placenta, and whatever it is formed, immunoglobulins are formed, so that will not cause harm to the first baby. Now you see the baby is fully developed, and then now whenever at the time of the delivery, so what happens, large amount of the RBCs may go to the maternal circulation. So here basically I want to tell you the placenta is attached in the utero, isn't it? So in the uterus, fundus usually attached, or in the body also it is attached. So whenever this placenta is attached in the uterus, so the placenta after the delivery of the baby, the placenta has to be removed. So now the placenta or the baby will get the nutrients and all from the mother, isn't it? So oxygen and all, everything from the mother. That's why there will be the, wherever the placenta is attached, so there may be the barrier, there will be the barrier, but still whenever this placenta is removed, that time the RBCs of the fetus or the RBCs of the baby will go to the mother circulation or the maternal circulation. So that time large amount of the RBCs may go to the maternal circulation. And so here what happens, this immunoglobulin G is formed, and it is not harmful to the first baby but harmful to the subsequent pregnancies. So now here it is not harmful to the first baby, because so whenever the first baby is there, that time because of the maternal this placental this barrier, blood barrier, this RBC cannot go to the mother, isn't it? So now at the time of the delivery, large blood will come, isn't it? So if you have seen any delivery, then that time placenta is removed, that attached part wherever the placenta is attached, that becomes raw, and then there will be the opening of the blood vessels. So a large amount of the RBCs will go to the maternal circulation. So that time whatever immunoglobulin is formed, it is not harmful to the first baby because it becomes more sensitized in the subsequent pregnancies. That's why the first baby will not be harmful. So now here in subsequent pregnancies, what happens? Now still, if the mother is RS negative, and then the fetus is RS positive in the subsequent pregnancies, then there will be the more and more this immunoglobulin G will cross the placental barrier and then it will go to the fetal circulation. But if the second fetus is RS negative, then there is no problem. There will be no problem. Understood here? So if the fetus is RS negative, there is no problem. Now, if the second baby is also RS positive or the third baby is also RS positive, now there will be the re-exposure of the RS antigen, isn't it so? So now here already RS positive is there. So now this RS antigen, there will be the re-exposure, and then so it will lead to the huge production of the immunoglobulin G antibodies in the mother. Understood here? So it will lead to the more and more production of immunoglobulin G antibodies in the mother. So these immunoglobulin G antibodies, now it will cross the placenta from the mother to the fetus. So here it's interesting only. So these immunoglobulin G antibodies, these are formed newly during the previous pregnancies, okay, which are formed newly or during the previous pregnancies. It will cross the placenta from the mother to the fetus. And now these antibodies or immunoglobulin G antibodies are coated on the RBCs, and now these are destroyed in the fetal spleen. So now the blood which will go to in the circulation, it has to pass through the spleen, isn't it? So that's why whatever these antibody coated RBCs are there, it will go to the fetus and it will go to the fetal spleen and then it gets destroyed there. Understood here? So finally it will lead to the hemolytic disease of the newborn or the erythroblastosis fetalis. So now more and more RBCs will be coated with the antibodies, that is the anti-RH or the immunoglobulin G antibody. So it gets destroyed in the fetal spleen. So that's why it will lead to the hemolysis of the RBCs, and then hemolytic anemia it will lead, immune hemolytic anemia. So leading to the hemolytic disease of the newborn, or it is also known as erythroblastosis fetalis. So actually it depends, depending upon how much of the anti-D antibody passes through the placenta to the fetus, the disease may be more severe or it may be mild, moderate to severe. Understood here? This is clear?
Ma'am,
Yes, please.
how does re-exposure occur? Like how does RBC from fetal goes to the mother's blood?
Now already with the first sensitization only, from the first sensitization, the blood is already exposed, isn't it so? Whereas D antigen is already exposed to the mother, isn't it so? That time there will be the formation of this anti-D antibodies, isn't it so? So now if the baby, and there is already a formation of the anti-D body, now if the fetus becomes again the RS positive, then that time all these antibodies will cause the lysis. Now these antibodies, whatever it is there in the mother's circulation, then it will go to the baby and then it will lyse the RBCs of the fetus. You wanted to say re-exposure. Re-exposure basically, now what happens in the subsequent pregnancies, I told you, isn't it? So in the second baby is also RS positive. Again, during the delivery, the D antigen will go to the mother, isn't it so? So it will lead to the more and more formation of the anti-D antibodies. So finally it will go to the fetus, and then first baby may be alive, but the second and then the third baby, it becomes more severe and more severe. Understood? Here, we will not ask you in such a detail as I'm teaching you, but you have to know that, okay, how the mother is sensitized, and whether the mother, what blood group mother has to be and what blood group fetus has to be. And Is it present in the first pregnancy? That you have to tell that it will not be present in the first pregnancy, but in the subsequent pregnancies, that antibodies will cross the placenta and it will cause the lysis of the RBCs. That you have to tell. Understood? So now here, whenever the mother is RS negative, so during the antenatal assessment, we have to do the determining this anti-D titer we have to see, or how much anti-D is formed in the mother, that we have to see. And in every 4 weeks until 28 weeks. So the baby will be delivered in 40 or 38 weeks, isn't it? So during every 4 weeks till 28 weeks, this anti-D titer we will do, and then in every 2 weeks we can do here. So now here, the mother will be given the injection, that is the anti-RS immunoglobulin antibody injection will be given to the mother by 28 weeks of pregnancy, so that whatever the fetal RBCs are there in the mother's circulation, that will be neutralized. So now here, this anti-RS immunoglobulin G antibody, now the fetal RBC will have the D antigen, isn't it? So this will attach to the fetal RBC and it will cause the lysis, so that it will not lead to the any more formation of the antibodies formation. Understood here? So it will be neutralized and maternal immune system does not become activated, or it will not be sensitized. So here we have to do the titration of this anti-D, and every 4 weeks till 28 weeks we can do, so that whether how much it is formed, is it high or it is low. Then after that, after 28 weeks, we can do it in every 2 weeks. So here, if mother is RS negative, usually whether the baby is, we give this one. So we give the injection of this anti-RS immunoglobulin, or the anti-RS antibody injection is given to the mother routinely by 28 weeks of pregnancy, so that whatever fetal RBCs are there, now the fetal RBCs will have the D antigen, isn't it? So now here, this D antigen and then the anti-RS immunoglobulin antibody, or the antibody to this antigen, it will cause lysis of the fetal RBC. So the mother will not be sensitized for the formation of this anti-D. Now for prophylaxis, now anti-D is given to the RS negative women within 72 hours of the delivery abortion, unless the baby is known to be RS negative. If the baby is RS negative, there will be no problem, isn't it? So whenever there will be the delivery, or whenever there will be the abortion, then anti-D is given to the mother who is RS negative. So what happens here? Now anti-D is given. So this mops up the RS positive RBCs of the baby, which have entered the maternal circulation before the immune system or this immune mechanism becomes stimulated. Clear? This slide is clear?
Yes, ma'am.
Anybody, anything you want to ask here? Now, in gist, I can tell you, here the mother has to be RS negative, and then the baby will be RS positive, isn't it? So now here, in the when the mother is becoming pregnant for the first time, or it is for the first time, or primary pregnancy, then that time baby's blood will not go to the mother. So at the time of the delivery, so whenever the placenta is removed, there will be the raw area and the blood vessels will be opened. So the fetal blood, it can go to the mother. Then whenever this Rh positive or the D antigen goes to the mother, what happens? It will sensitize the immune mechanism or the immune system of the mother, and it will lead to the formation of the antibodies against that D antigen, isn't it so? So whenever this D antigen goes to the mother, and then the antibodies are formed. Now in the subsequent pregnancies, if the baby is again RS positive, then this D antigen, whatever it is formed, it will cross the placenta, and then it can cause the lysis of the fetal RBCs. So here I told you at first it will be of the immunoglobulin G type, and whenever again the next baby will be of RS positive, then that time it becomes the immunoglobulin. First it will be immunoglobulin M type, and later on it becomes the immunoglobulin G type. So here nowadays we don't see that much this complication, but it also occurs. I want to say that. So in the previously in old long time ago, then okay, there was only one baby, and then the subsequent babies dies. So that time the mother or this blood grouping did not was not possible, isn't it? So that's why the subsequent baby, they must have died because of that one only. So that's why to compensate this or not to happen that fetal death, we can give this anti-D to the mother, so that whatever RBCs has entered in the mother circulation, that will be lysed. Anybody asking a question? Who's talking? Now you see at the time of delivery 20 ml of the blood should be collected. So now here we will collect the 20 ml of the blood, and we will see the direct MCOMS test along with the ABO and then the RS grouping. Understood here? 20 ml of the blood should be collected from the cord blood, and then we will do the direct MCOMS test, and then here we will do also the ABO grouping and then the RS grouping. ABO, whether the baby is ABO blood group, which blood group is there, and then whether RS grouping also we will do. We want to see whether the baby is RS positive or not. Now you see here baby's blood group. You can see this slide.
Yes, ma'am.
Okay, now here if the baby's blood group is taken and then it becomes the direct MCOMS test, we will do the direct MCOMS test, and if it is positive, then we will collect the mother's blood, and then we will do the indirect MCOMS test. So here in the baby we will do the direct MCOMS test and then the indirect MCOMS test, because here in the baby we will do direct because we want to see the attached antibodies on the surface of the RBC, isn't it so? But in the mother, this antibodies are not attached on the surface of the mother, isn't it so, RBC? So that's why it is there in the plasma, isn't it? So that's why we will do here the indirect MCOMS test, but in the baby we will do the direct MCOMS test. So here you have to remember, in the baby we will do the direct MCOMS test. Then if the baby's blood is positive, then we will collect the mother's blood and we will do the indirect MCOMS test. So in the baby direct MCOMS test we are doing because RBCs, that D antigen is attached with the antibodies, isn't it so? But in case of the indirect, mother will have these antibodies in the plasma, isn't it so? So that's why we'll do the indirect MCOMS test. So now we'll come to the clinical features of hemolytic disease of the newborn. In mild cases, only anemia will be there. But in severe cases, there will be the marked edema will be there, and then there may be the jaundice due to high bilirubin level. So more and more lysis will be there. That's why there will be the more of the unconjugated type of the bilirubin will be there. So this unconjugated bilirubin may be deposited on the brain. So whenever it will, this unconjugated bilirubin will be more, it can cross the blood-brain barrier of the baby, so it will lead to the kernicterus. So kernicterus means, so it will, this unconjugated bilirubin will be deposited in the basal ganglia, thalamus, cerebellum, and even the gray matter and the spinal cord. Understood here? So now here to have that kernicterus, usually the bilirubin or the unconjugated bilirubin, it has to be more than 20 milligram per deciliter. Understood here? So the babies will show the neural damage, and then the seizures will be seen. So whenever this bilirubin in a small baby, it gets attached in the basal ganglia, thalamus, cerebellum, and then the cerebral gray matter and spinal cord. So it will lead to the neural damage and seizures. Understood here? Mild cases, only anemia will be there. But in the severe cases, it will lead to marked anemia, means more anemia will be there. and it will lead to jaundice due to high bilirubin level. So the baby will look yellowish, and that is because of the unconjugated type. And unconjugated bilirubin may be deposited in the brain. So whenever the unconjugated bilirubin gets deposited in the brain, that is known as the kernicterus. So here, this unconjugated bilirubin will get deposited in basal ganglia, thalamus, cerebellum, cerebral gray matter, and spinal cord. Now, this bilirubin will cross this blood-brain barrier whenever this unconjugated bilirubin is more than 20 milligram per deciliter, and it will cause the neural damage and seizures. Clear this slide? Did you understand the slide?
Yes,
Yes,
ma'am.
Okay.
Yes, ma'am.
Now signs and symptoms, not much difficult, isn't it so? Now to compensate marked hemolysis. So hemolysis will be there in the baby, isn't it? So now to compensate that hemolysis, there will be the increased RBC production in the marrow and also in the other organs like liver, spleen, lymph node, kidney, lung. So there will be the it will lead to marked anemia. So hemoglobin level will be very much decreased. So there will be the RBC production in the marrow. And so the RBC production, it can also occur in the liver, spleen, lymph node, okay, it has become lymph node. So it is in the lymph node, kidney, and lung. Whenever RBC production or this RBC compensation occurs in the liver, spleen, lymph node, kidney, and lung, that time it is known as extramedullary hematopoiesis. So medullary hematopoiesis means the bone marrow, isn't it? In the bone marrow, it is known as the, usually hematopoiesis occurs there, but whenever it occurs in liver, spleen, lymph node, and kidney or other organs, so that time it is known as extramedullary hematopoiesis. So the peripheral smear shows numerous reticulocytes and erythroblasts. So in your anemia class, you must have known what do you mean by reticulocyte, isn't it so? Yes?
Yes.
What special?
Yes, ma'am.
Okay, what special stain you will do to know whether it is reticulocyte or not?
Supravital.
Good, okay. Supravital stain. Why do you call supravital stain?
We don't fix it.
Good, because the cell is still alive, isn't it? So that's why supravital. Vital means alive, isn't it? So it is done outside the body in a living cell. That's why it is supra, means super. Okay. So the peripheral smear shows numerous reticulocytes and erythroblasts. You know erythroblasts?
Precursor there.
Precursor there. RBC, does it have nucleus?
Mature don't have.
Mature don't have, isn't it? So now here erythroblast, it will go to the circulation. That's why the name is the erythroblastosis fetalis. So whenever in this fetus we draw the blood, we'll see so much reticulocytes and then the erythroblasts. That's why the name is the erythroblastosis fetalis. Name is given because of that one. We will see the erythroblast in the fetus. So that's why it is known as erythroblastosis fetalis. So in very severe cases, generalized edema due to hypoxic injury to the heart and liver. Why generalized edema? Hypoxic injury, why? Did you understand here? Because the RBCs, whenever it is mature, then only it will, RBCs will take, the hemoglobin will take the oxygen, isn't it? So now here, there is marked edema is there, and then hemoglobin is also less, isn't it? So and then all these immature erythrocytes or the erythroblasts will not be able to take the RBCs, will not be able to take the oxygen. That's why it will lead to generalized edema due to hypoxic injury to heart and liver. So there is also extensive edema in the subcutaneous tissue. Extensive edema means there is the accumulation of the fluid in the subcutaneous tissue, different organs, viscera, also in the peritoneal, and then the pleural spaces. So whenever you know the osmotic, how it occurs, isn't it so? So whenever there is the RBCs and then the plasma is there in the blood, so it will retain the fluid also. So now whenever RBC also, hemoglobin is also less, RBC is not there, so it will lead to the fluid to come out of the blood vessels, and it will lead to the edema. So extensive edema in the subcutaneous tissue, different organs, like in case of the peritoneal fluid, organs means it may be in the liver, lung, kidney, and also in the peritoneal and in the pleural cavities. So it is also known as the hydrops fetalis. So now hemolytic disease of the newborn, erythroblastosis fetalis, it is also known as the hydrops fetalis. Hydrops fetalis because hydrop means water, isn't it? Hydro means water. So here there is more accumulation of water in the fetus. That's why it is known as the hydrops fetalis, and it is often fatal. So now you see here baby. Now you can see this belly is distended, isn't it? So belly is distended. It means that there is much accumulation of the water is there, or the fluid is there, and in hand, and then the face is also swollen. Now, can you make out this baby is yellowish in color? Yes.
Yes, ma'am.
Yellowish in color.
Yes,
So, okay.
ma'am.
So here, because of the more and more unconjugated bilirubin, understood? So here there is a bilirubin deposition is there, mainly the unconjugated bilirubin is there. So, and then the baby is also edematous, and belly or the abdomen is also distended, and flank is also full. So this is the hydrops fetalis. So another baby also, the baby you can see here, abdomen is distended, isn't it? So, but here that much jaundice is not here. Now we'll come to the ABO, this hemolytic disease of the newborn due to ABO incompatibility. So I told you about the RH incompatibility, that is the erythroblastosis fetalis. So here we'll talk about the ABO incompatibility. So here this ABO incompatibility, it is much less severe. And so here the mother has to be the blood group O, and then the fetus it is either A blood group or the B blood group. If the mother is O blood group, what is the antibody in the plasma? Tell.
Anti-A and anti-B.
Good. What's your name?
Ujjal.
Ujjwal what?
Ujjal Sapkota.
Okay, good. I hear your voice often. You are answering. So now you see here we'll talk about the ABO incompatibility. So it is not very severe. So here most anti-A and then the anti-B antibodies are immunoglobulin M type. So here I told you M type, it doesn't cross the placenta, but the immunoglobulin G type crosses the placenta, isn't it? So they cannot cross the placenta. Understood here? So most anti-A and then the anti-B. So now here anti-A and anti-B is there in the mother, isn't it? So because the mother is O blood group, that's why anti-A and anti-B is there in the mother. So now it will not cross the placenta and it cannot lie. So in fetus, there is the expression of the antigen A and B. These are not strong. I told you this whenever we will do the fetal blood grouping, that time it will not show the proper as in case of the adult. So in the first class, I told you, if you remember, so for the fully development of this antigen or in the antibody, so it will take 1 year. Did I tell?
Yes, ma'am, you told.
Okay. So in the fetus, there is the expression of the antigen A and then the antigen B, and which are not strong. So if a person is A blood group, that time in our body, other cells will also express this antigen on the in their cells. Understood here? So different cells express A and then the B antigen. So if somehow, if now it will not pass through the immunoglobulin, this M, it will not pass the placental barrier, but somehow if it crosses the placental barrier, so these antibodies like anti-A and then the anti-B, which is there in the mother, because the mother is O blood group, isn't it? So this will go and attach to the other cells, and antibody gets attached to the other cells rather than the RBCs. So that's why it is not very severe. Understood this slide, or should I explain it once again? So here in ABO incompatibility, mother has to be blood group O, and then the fetus has to be A, and then the B or the AB blood group, isn't it so? Usually in case of the mother blood group O, there is no antigen on the surface of the RBC, but in the plasma there will be anti-A and then the anti-B in case of the blood group O, isn't it? So usually in the fetus, this whatever antigen is there, antigen A, antigen B, they will not be very expressed, isn't it? So in case of, and it will take 1 year time to express all these antigens. So that's why whenever this anti-A or the anti-B antibodies of the mother, it will go to the fetus. That time it is not developed on the RBC, but somehow it is this antigen A and then the antigen B, it is also seen in other type of the cells, like in the other cells in our body. Millions and millions of cells are there. So those cells get attached with these antibodies, but not to the RBCs. That's why it doesn't cause much harm to the fetus. Understood? Clear?
Yes, ma'am.
Only one yes.
Yes, ma'am, clear.
Yes, ma'am.
Okay, today's class is finished. Anything you want to ask?
Ma'am, in that direct MCOMS test, what we see?
I'll tell you in the later classes.
Okay, ma'am.
Okay. And in the direct MCOMS test, we just want to detect whether the RBC is having this antibodies or not. Understood here? Baby is RS positive, that is having the D antigen, isn't it? So, and then the mother's antibody will go and attach to it. So we want to see whether the mother's antibody is attached on the RBC of the baby or not. So that's why with the help of this direct MCOMS test we are telling, because we want to see the antibodies on the surface of the RBC. That's why it is the direct MCOMS test. But in the now, if the baby's direct MCOMS test, it becomes positive. So in the mother, we want to detect whether these antibodies are there in her plasma or in the serum. That's why we will do the indirect MCOMS test, and then we will see whether this is present or not. It will come later also. Anything you want to ask? Everybody understood Ranju Adhikari?
Yes, ma'am.
Any questions?
No, ma'am.
Okay. Yashi Chaurasia, are you there?